Hello and welcome to the Parliamentary Friends of Palliative Care September event. I'm Norman Swan, hosting this event for you, and I'd like to, before we go any further, acknowledge country. We are broadcasting to you from Gadigal land, part of the Eora Nation, and we pay our respects to past elders, to present elders, most important of all, to future elders. It's a great honour to show our respect to those elders and to the land on which we meet. No community is in greater need of the sort of services and thinking that's involved in palliative care than Aboriginal and Torres Strait Islander communities. The focus today is palliative care in aged care, and it's part of the campaign from Palliative Care Australia called Palliate, and ensuring palliative care is core business for aged care. Important issues, and Palliative Care Australia has come up with an 8-point plan, which we're going to discuss, as well as the implications for older people themselves, for palliative care community, and for aged care facilities, as well as for training organisations and academic organisations. We'll particularly look at two of the areas in that plan. One is training and skills development, huge issue. You can't have avoided that issue in the last 6 months, and we'll not ignore the elephant in the room, which is COVID-19. And of course, you can't do it without appropriate funding. How does that happen? Who does it? And how is that coordinated? Before we go any further, I'd like to throw to the conveners of the Parliamentary Friends of Palliative Care, the co-conveners, Senator Katrina Billick and the Honourable Nola Marino MP.
Hello everyone. Welcome to our Parliamentary Friends of Palliative Care. It's great to have you with us once again. I'm Nola Marino, the Federal Member for Forest in Western Australia, and along with my colleague, Katrina Billick, we are the co-conveners of the Parliamentary Friends of Palliative Care. Now, this group is really important in our Parliament because it brings to every member, it's bipartisan, so right across the Parliament, members are invited to come and hear more about the issues surrounding palliative care. And that wonderful forum is ideal to discuss and raise issues that are important in this space. So Katrina and I feel very strongly about this.
Thank you, Nola. That's very true. Good morning. I'm Katrina Billick, Senator for Tasmania. Let me join with Nola in welcoming everybody today. We'd also like to extend a very warm welcome to our guest speakers, Mike Baird, Professor Deb Parker, Craig Gear, Professor Mira Agar, and of course, our MC for today's event, Norman Swan. There's always strong interest in these Parliamentary Friends events. As Nola rightly states, there is support for palliative care across the Parliament. But even more than that, death and dying is universal. Everyone's life has been or will be impacted or touched by the death of a loved one. And many of us here today have known family or friends who have received palliative care.
Equally, as a minister with responsibility for some of the regional areas in Australia, we really understand very much the importance of palliative care in regional areas, especially in our small communities.
2020 has been an extraordinary year. COVID-19 has meant that as a nation, our collective conscience has been focused on death and dying for much of the year, and with a greater intensity and consideration than we would normally. We are also witnessing a critical and necessary focus on aged care. This is as a result of both the Royal Commission and the numbers of COVID-19 cases and deaths in aged care residential facilities, and this focus has reinforced the obvious but perhaps overlooked connection between aged care and palliative care.
So today, as you look at the really critical importance of palliative care, COVID and beyond, I really thank you for being present today and everyone who's taking part in this Parliamentary Friendship Day. Thank you very, very much.
Thank you, and back to you, Norman.
Thank you, Katrina Billick, and to Nola Marino. Our panellists today are Professor Mira Agar, who is the board chair of Palliative Care Australia, Craig Gear, who's Chief Executive Officer of the Older Persons Advocacy Network, that's OPAN, Mike Baird, as you heard before, CEO of Hammond Care, all of 3 weeks, a world authority on aged care, Michael.
Let's call it a fresh perspective.
And Professor Deb Parker, who's Professor of Nursing Aged Care with a particular reference to dementia at University of Technology, Sydney. So welcome, Deb. Welcome to you all. Mira, excuse me for just a slight scepticism here. I mean, 36% of Australians die, in aged care facilities. So where does palliative care actually fit in when, in fact, it's your home and you die in your new home?
So I think we need to remember that whether you're in a hospital or at your community home or in a residential aged care, if you have a medical illness that is going to lead to deterioration and death, you will have clinical needs, you'll have social needs, and you'll have emotional needs, and your family around you will have those needs. And palliative care is about delivering care, whether that be clinical or social or family support to meet those needs. And so the location of where you are is almost a secondary issue. It's about fundamentally what are those needs, and then within that context, how best can we deliver that?
So do you have any data on the underutilisation of palliative care? In other words, of all the people who merit it, who does, the extent to which they don't get it compared to the general community?
So I think the challenge is that we have three levels of need. We have people who have more moderate needs where the facility and their primary general practitioner can meet those needs. It's when you have more intermittent complex needs or continuing complex needs that access to more specialist services become a problem. And we also know that there are unmet needs in terms of the more general needs where we would expect that the workforce within aged care should have capacity to respond to those. And there's published literature that says that those needs are often not met or not met in a timely way.
But come back to my question though. Do we know the extent to which people are getting access to palliative care at the moment who need it?
So we do know that there is a restriction in the capacity of specialist palliative care to go into aged care facilities, and that's across the country.
Okay, we'll come back to the impact of COVID-19 in a moment. So what is this 8-point plan?
So it's really focused on, we need tailored and timely response to those palliative care needs. And to be able to do that, we need the workforce capacity. We need to be able to measure that we're actually achieving those needs being met. And then we also need to make sure that we have a system that's designed properly and funded, and a whole of government response, because I think the challenge is that this crosses both state and Commonwealth approaches, because community and specialist and aged care sit in different areas of the government response.
So what training is needed and by whom, well, for whom and by whom?
So I think there are several levels. There are the clinical competencies. There's the attitude and beliefs about what palliative care is and what the needs of people may be, and communication with people who are reaching the end of their lives.
Because aged care will be no different from anywhere else. They'll think of palliative care is just for the week before you die to get morphine.
And I think palliative care is about proactive care,
which is medium to long term,
and needs a really meticulous assessment skills, and not dealing with things as they emerge in a crisis, rather than working out what might actually be the things that might happen for this person, and what could be the plan that we could put in place to proactively have that care delivered when that person may need it in the future.
Let me take a cynical point of view, which is, what's in it for the facility itself? So, okay, you're providing humane care, so that's a good thing to do. It's the right thing to do, that's a good thing to do. But what benefits would a facility see for implementing palliative care in their residential home?
Well, I think you're moving from crisis-driven care, where you're going to still need to put that clinical response or social response or communication with family in place, but you're doing it in a way where you can be much more sure of where your resources will be needed, and how much of it will you need, and the problems I think issues like complaints. Why not have the conversation with the family in a positive light about let's plan for future care, rather than having that conversation when things have not gone well. And so it's about investing in a positive and proactive approach rather than reacting after the event, and using resources, I think, in a wiser and more efficient and effective way.
We'll come back to some of the specific issues in a minute. Craig, what are older people and their carers and their families telling you?
Yeah, Norman, people are saying that they want choice and they want control, and particularly, I suppose, they want a good life, but they also want a good death as well. So they want it to be an experience that is, I suppose, when we were talking about that relational connection. And sometimes that's challenging in the busyness of an aged care home.
Before you go on, I mean, do people who are putting their loved ones into residential aged care, or people going in, do they think that's where they're going to die?
Not necessarily. I think I take the example of my own grandmother, who was there for 11 years in a really beautiful facility. But even our own family didn't talk about palliative care until very close to the end. And we were lucky and got palliative care team involved as well. So I don't think people are necessarily thinking about dying or that part of the journey. And I think this sort of training, this sort of investment means that sort of these sorts of journeys and discussions can happen much earlier on.
We've got to create a demand.
Oh, yes.
And people are frightened of palliative care because they think, well, I'm going to refer you to palliative care. Does that mean I'm dying next week?
Correct.
Sort of thing. Rather than, as Mira implied, you could get palliative care 2 years before you die, because it's just about planning, symptom control, making you more comfortable. In fact, you live longer, is the evidence, if you get palliative care, rather than more curative care.
Absolutely, and that's what older people are saying, and their families are saying. They're at least feeling that they're in control. They've got choice, and that's really important for people to not lose that aspect of choice, and this really helps with that.
Do you think people know what it looks like, though, palliative care?
No, I think it's so misunderstood or underunderstood in Australia, and I think that's one of the great opportunities of something like the 8-point plan, is to start raising the profile of it. It's such a beautiful part of life as well, but it needs to be talked about and needs to be part of just what we do in life.
How much of this is about what people call death literacy?
Absolutely. Like, we don't have health literacy in Australia. If you try and navigate the aged care system, that's challenging. If we try and navigate the health system, but we need to navigate the death system as well, and be comfortable to have those conversations, have them as a family as well, plan for this. Mike
Baird, Hammond Care's got a reputation of being a bit ahead of the curve, particularly in dementia care. But even so, as running a large set of residential facilities in an era of COVID-19, somebody says, well, you've got to do palliative care as well. It's enough to give you a rather large migraine.
Well, no, I don't. I mean, I don't think so. I think it's central to what we do. If you think, we heard about the opportunity through palliative care to take sort of longer term decisions and involving both the patients and their families. Well, that's something that's really important to us. That the sooner that you have an opportunity to engage and say, well, we're heading a stage, towards the end of days, and it might be sort of weeks or months ahead, and think of dementia, it's potentially years. But sort of understanding what comes on the journey, understanding the various choices that we might have to make, as in collectively family and the patient, and being prepared for those, I think is an incredibly important thing. And ultimately, we heard, clinical care remains essential, but as we're sort of on a palliative care journey, it kind of shifts to the whole person. And obviously at Hammond Care, we place the whole person at everything we do. But understanding their mental, their obviously social, their spiritual needs, as well as the clinical. And as part of the palliative care journey, that becomes incredibly important. So the more that families are engaged, the more options they know, what's going to be on the journey, the medical choices. And sometimes, with obviously dementia, the earlier you have the opportunity with sort of cognitive capacity, you can sort of make those decisions collectively. And rather than just sort of getting to the last 48 hours or 72 hours, you miss many opportunities on the journey.
But it's not a sector with a great reputation at the moment, as you well know. And prior to the COVID-19 pandemic, Royal Commission into aged care, some notorious examples of very poor aged care, and the weaknesses revealed in bulk, particularly in Victoria, but to some extent in New South Wales. But anywhere in Australia could have experienced this because the same system prevails. If you can think about across the sector, if they can't get infection control organised, how are they going to get palliative care organised? I mean, and aged care operators will be thinking that themselves. God, I've got a priority now to get PPE and train people who are almost lay workers in a home situation rather than a clinical situation. How am I going to do palliative care?
Yeah. Well, I mean, I think obviously in terms of COVID and infection control, there's been a lot of sort of education, a lot of progress across the sector in the past few weeks and months as was needed. But look, I just reflect, Norman, on what I've seen. I mean, clearly, I've sort of heard some of the stories that make your heart break, and none of us would want to see sort of any of those. But, we haven't heard as much about some of the incredible stories. And, I've had the privilege, and I describe it as a privilege, to go and meet with our staff and team at the front line, our care workers and our nurses and clinicians and sort of everyone in our residential care systems and facilities who are, as one, trying to improve the quality of life that they are serving and caring for. And I could give you sort of already 20 or 30 examples where I think that is exactly how I'd want, my mother or my father or, someone I loved to be looked after. So there are undoubtedly learnings across the sector. And I think that this process, my hope it becomes incredibly constructive, that it's actually a turning point in the nation where we determine the value of our elderly. I mean, I think that's something that's awesome. And as providers, we need to individually take on the best practice that we're seeing, work with government in terms of what's the best way to regulate and fund, and obviously we'll get to that. But I see this as an incredible opportunity to not only just deal with infection control, but to deliver in a wonderful way care for our elderly Australians for the next generation. And obviously, palliative care is part of that.
So Deb, take me through the implementation path. So people are watching this from aged care as well as palliative care, and you've got to educate and train a new workforce who are not necessarily clinical. I mean, there are very few nurses in aged care, but there's lots of ancillary and caring staff. Nobody wants to do a bad job here, but you're talking about a system where the business model doesn't necessarily favour a lot of training on the job. So there's training at a certificate level, I suppose, before you get the job, but you're already on the job and you want to upskill them. Just take us through that broad picture of how you implement training.
Yeah. So I think there's a number of things that I think it's a really exciting time. I've been in the aged care sector for, almost 3 decades. I think it's an incredibly exciting time now. Unfortunately, we do have COVID, but in terms of what's available and where we're going with training, so, we have the certification 3, the personal care worker. Now, unfortunately, that does not include a component of palliative care. It is the entry level sort of training. The Cert 4 does, and so we do have within the sector people who have had that level of training, and there's a palliative care component to that. So they're coming into the workforce with that.
But I've had a look at the Cert 3, Cert 4 curriculum when it comes to infection control, and it's pretty perfunctory, and it's clear from the problem. If this was one bad egg, in Victoria, where you've just got one really badly run aged care home, you wouldn't have had 160 aged care facilities affected. This is something that's not the fault of individuals. There's something wrong with the system, and presumably just taking infection control as an example, and now you were talking about adding on palliative care, the learning has not been strong, I assume, and people have not necessarily known what to do, even though they've ticked the box on the training module. Yeah,
although I think, it's interesting when you're talking about the level of knowledge that people have for infection control, because we have the influenza outbreaks and gastro outbreaks and things, regularly in residential aged care facilities, and they're actually managed very well. COVID, no doubt, is a, it's on its own, isn't it? And I'm not sure whether it's just the lack of infection control that is the issue there. I think there is broader system issues. Community transmission in Victoria is absolutely critical to what's happened in Victoria, because we're not seeing it anywhere else. And we saw that in Europe and UK and Canada, and my colleagues over there were like, wow, Australia's doing an amazing job. You're not seeing that. So I think, so I think it's about stepping up, isn't it? So the training that we've had in place was never designed to deal with COVID. It was designed to deal with infectious conditions that were less rampant than something like COVID. We don't generally put on PPE.
I don't want to spend the whole program dealing with COVID, but I do want to ask you, what have you learnt in terms of training and education from what's happened with COVID-19? Because clearly, if you're lucky and there's low levels of transmission in the community, you're not going to get in, although you did have Newmarch in New South Wales, but when there was a bit more community transmission. But once it's in, you've got a problem. But what have you learnt from that you could apply to the training that's got to happen for palliative care?
Well, I think the other thing, though, is that we've been training people in aged care services, whether it's residential aged care or home care services, for over a decade. We've had national programs.
In-service training.
In-service training, which is, there's thousands of workers across Australia who have attended those programs, whether it's face-to-face or whether it's online. We have end-of-life directions in aged care, which I'm a co-lead of with Patsy Yates and Jennifer Tierman. We have had a massive surge since COVID. So I think there is that link between people wanting to understand the importance of those conversations. Advanced care planning has been very popular in terms of the hits that we're getting. People are really wanting to understand, what does advanced care planning mean in the context of COVID? And I know Mira and I have had these discussions around.
In fact, it was the topic of the last webinar.
How valid is somebody's advanced care directive or plan when we didn't know that COVID existed, and then what do you do around that? And those, really important sensitive conversations then that need to happen with the person if they can have it, or with their family members. So I think the fact that we've been in this space for a long time, sometimes it's you need to be at the right place at the right time, don't you? And I think palliative care, because COVID has shone that light, I guess, on the deaths that have unfortunately occurred in the residential setting in particular, I think people are ready to, if they haven't been engaged with us, are going to be more ready to engage with the topic of palliative care. And it's been a topic within the Royal Commission. It is a focus. We have different reviews of training package. I noticed that the EN training package has just been reviewed, and they've put palliative care as the enrolled nurses training package has just been reviewed at the moment, and they've put palliative care as a core component in that. And Patsy Yates' work up in QUT, she has fantastic online resources ready to go into all of these training packages. And now that you're shovel ready. We're absolutely shovel ready. And now we're in a digital space. So people actually, where they wanted you to come out and do a face-to-face workshop, now understand I can do it online. I think we're going to see a huge surge in the knowledge and capacity within the sector.
So just give me a sense of the practicality here. So I'm running an aged care facility, and I do want to upskill key staff in palliative care. Costs, time involved, access, just play that out for me.
Free.
Free
education.
So funding's not a problem then.
So not accessing the education, of course, there's staff time and costs, and I think that has to be built in. I think the other thing that
So what you're saying is the institutions need funding to provide it free to aged care facilities?
Well, the products are freely online, available on demand, so that's there. But I think one of the things that we know from implementation science evidence is that education alone doesn't change what it is that you do. So we need system change, we need change at the organisational level, We need change at the level of the actual facility, and then we need change at the level of the individual. So the products that we've been developing over many years, actually on a range of topics that will assist. But I think you have to have commitment. And like Mike, I've worked for many years with many, many committed organisations in aged care who get it. They invest in their staff. They invest in having a process and staff within the facility to take the lead, to make this happen. They put the systems in place, and they are the success stories. And then other organisations can learn from those people. And that's what happens when you have conferences and other events where people can see what's happening. So you just get the word out, it does filter out.
So one of the issues before the Royal Commission will be, already is should privately run aged care facilities, and I'll come back to Mike in a moment as to whether or not he has those at Hammond Care, but should registered nurses be more pervasive within the private sector?
Oh, absolutely.
So yes is your answer.
Oh, absolutely.
So that would aid aged care as well as infection control is really what, it's
yes,
palliative
of
care, I
course.
should say.
Of course, we're a highly skilled workforce that has been depleted since the 1997 Act in aged care, where we were, basically removed as the core staff. And I really also want to make the point that one of the key things that will come out of the Commission is it's not only residential aged care. We have a large proportion of older people at home receiving CHSP or home care packages. And we've heard recently in the most recent hearing that the registered nurse is absent in those high-level home care packages, 15 minutes a fortnight on average for somebody receiving a level 4 package. So how can we say that we have created a system that is supporting people to stay at home, get palliative care, and to receive the care they need when we haven't funded it?
So Mira, that's presumably where the dollars hit the road. So it's not the training so much as the skills you need on.
You train care work. I've had the experience where the care worker has very clearly identified the clinical need. They're trying to articulate that to someone, but they don't have the clinical support to help them then coordinate and come up with the clinical plan, and then they can go back and deliver that, and they're very passionate to do that. And sometimes training and improving the knowledge and attitudes of some part of the workforce actually compounds the problem, because then they can't, they really won't ignore the problem, and they might send someone to a hospital if they really feel someone has a symptom distress that they're not getting
So you create
assistance.
a demand which is not necessarily served.
And that's very difficult when you've got someone who's really passionate about solving a problem that they've learned about, when they don't have that clinical structure to support them. And I think I agree with Deb that those systems that have invested in those clinical roles, and I think you've got to combine training with mentorship, bedside role modelling, because applying that in each individual situation, every resident in Australia has a different set of attributes and clinical needs, and applying that takes experiential teaching, and that's the bit that's missing, I think.
So Craig, Mira's hit on an important point, whereas you do the right thing, you give consumers knowledge, you give the aged care workers knowledge, but it could create a set of frustration. In fact, modelling in mental health care shows the same thing, that if you, in Western New South Wales, they did a study where they looked at training GPs up in mental health care, actually made the problem worse. Yes. Because it created demand for which there was no services to link to. Correct. Yes. So just to join the dots for me in terms of consumers.
So the consumer wants obviously to have knowledgeable staff. They also want staff with the right attitudes and the right skills. And so there is, I suppose, a need to make sure that is sitting behind in this system. And the empowered consumer, though, will be asking, or the empowered family will be asking these questions. Aged care is such a relational industry setting. Really, that care is done through connecting with people. If people are not also being invested in that, then that's a gap that will be there as well. So it's a combination, I think, of the need of the clinical backup, the nursing backup, but also the right attitude and the right connecting with people as well in this. And that's what people are telling us they're looking for.
Mike, what's your comment on this? That if you don't do it as a system-wide, you're going to create problems for yourself.
Look, I think you're sort of probing in on the right sort of issue. But firstly, it's fantastic to have education available free, and the work that you're doing is incredibly important. What we're trying to do is work out whether it's sustainable. So on both sides, what are the impacts and what are the benefits? What are the outcomes? So we're running a pilot program sort of as we speak with a couple of our facilities and RSL to look at actually providing palliative care sort of education and training to our staff over 10 weeks. And sort of looking at the benefits and what we learn from that and how we could potentially make that sustainable. So, like, it's new, but I think your point, we can't just sort of provide this course and think we're done. It's like, well, how is this actually working? How is it equipping sort of our workers in a way to maybe identify risk early, to know who to involve earlier, how to care for families when that mightn't have been a consideration. And I certainly think that that is incredibly important, because the demands on our staff in the front line, as you've said, whether it be sort of COVID or just sort of day-to-day pressures, are intense. This is not necessarily something new. It's just more sort of emphasis and focus on things. Some things are already doing, but it kind of gives a holistic approach.
Well, it could make some stuff easier.
And absolutely.
So what about this issue of unskilled staff? We've got a few questions here about that. Is that notoriously aged care has de-skilled and got people in at a lower level where they don't have the higher level clinical skills in a population that's potentially much sicker. What's your perspective of that? And, I mean, do you have registered nurses as a routine in Hammond Care?
I mean, we do, but obviously we have sort of care workers as well. And I think, look, I'd start with the fundamental premise. You need someone to have a heart and a compassion for caring for the elderly. And if you have that, well, that's an incredibly good place to start. And then experientially, you can start to develop the skills. And we were discussing this morning, is that in terms of what the Royal Commission is talking about and where we're going and how do we address these additional skills, is a form of apprenticeship sort of style approaches. That's something that we look at, along with the kind of the Cert 3. Is there sort of on the ground experience that we can kind of supplement to kind of develop those skills. So, we think sort of both. Of course, we need sort of clinical expertise, but you need sort of care workers both. Kind of have to have the capacity of a desire and a heart to look after the elderly. But there's no doubt that more skills and training is going to be beneficial to everyone. No doubt about it.
And the funding implications, because there's going to be a lot coming down the pike from the Royal Commission, not just on COVID-19, not just on palliative care, but top to bottom, side to side.
Yeah, and look, I think if you start with the premise, yes, the federal government is challenged and their budget is only getting worse by the day. But if there is a view, and as a nation we say, actually our elderly deserve much better care than they're currently getting, and that becomes a national priority, well, the funding will follow. The question is, money doesn't solve it alone. It has to be done in the right ways, with the right programs, with the right sort of outcomes that are measured. And from our point of view, if we start to look at even the palliative care home support program that we have here with the New South Wales government, there's incredible opportunities in that. We do it with them. We've served over 5,000 patients. About more than 70% have actually died at home. And if you go through the other numbers, I mean, it's pretty much on average less than 20% actually die at home. So it's 3/4 Australian actually want to die at home. So safe, in a controlled way, that can be delivered much better outcomes to them and their family, and it can be delivered for about a third of the cost. So Chris Poulos, a professor with us, has done some research on this. So from a government policy point of view, well, it's not often that you get sort of better outcomes at a lower cost. So there is potential with the state governments and Commonwealth governments sort of coming together that, that funding, that collective funding pie, which would be the way I'd look at it, could actually go further.
Bina Brown, who's Director of Third Age Matters, asks, given the preference for people to access aged care and remain in their own home, is there a plan to make palliative care in the home more accessible to the elderly, and will the planned training extend to home care support workers? I'll come to you first, Mira, and then maybe Craig, and then Deb.
No, I think there are a lot of older people who are on a level 2 package who really need a level 3 or 4, who either die at home waiting for that with inadequate services, or need to then enter residential aged care because that package is not going to be available in the foreseeable future. So we have a challenge in terms of just numbers of packages and availability, and responding to that in a timely way.
Do the packages allow for palliative care at the moment, or are they inflexible to palliative care?
They're inflexible, I think, and it's about timing, that you need the package when you need it in palliative care. You can't say, well, we'll put you on a wait list, and there needs to be some approach that actually says this service is needed now, rather than a system that's just relying on the next person, because it's, you might fund the right service, but it's too late. And so I agree with Mike that it's about not only the funding, but it's how it's delivered, and having state and Commonwealth programs actually communicating with each other so that you can actually move a resource from here to get it to that person at the right time, which then avoids the hospital admission that happens at 2 a.m. Those are the fundamental problems, I think, in terms of how the system works.
Yeah, and when people are saying that, I mean, it was meant to be consumer-driven care, consumer-directed care. And the challenge has been is that when people are saying they want palliative care at home and they want to stay at home, age at home and also die at home, the resourcing sort of sits in different systems, the state system where a lot of the palliative care resources are. So we definitely need to do a lot more. We're having calls every day of people saying, I want to stay at home, I need more care and support. And that care and support has to be able to be tailored to them to say, it's palliative care that I want as part of this as well. Just not just personal care, but I want the palliative care overlaid to that, so I can have a good time while I'm at home as well. Yeah. But
palliative care is not necessarily well integrated into that system.
In the home care system, I think that has been one of the issues, that when we've changed from the old CACP each program to the consumer-directed care, I think we went very much around the social model of care when we changed over to that consumer-driven approach. I've already spoken about the fact that, we have a lack of visibility of registered nurses in the home care setting, which we didn't have in the previous package setting. There was a much more visibility of the registered nurse. So I think partly it's about what do I see my package as? Like what am I getting from the government? And then when my care manager or the person who's going to come out and negotiate, I've got a level 1 or level 2, 3 or 4 package. What does that look like? And what is the lens by which they're thinking and walking you through that? And so if
it's a mirage, isn't it? I mean, it's not consumer-directed care at all. I mean, it's a political myth.
Well, it's consumer.
It's a con.
It's about how much choice you do have and you don't have if the choices aren't put on the table, isn't it? So I guess where I'm going with that is if I'm discussing my package with somebody who's not got the lens of you're on your package, and part of that package is to make sure that we have the systems in place so that you can stay at home with your life-limiting illness and your package can accommodate those needs. And yes, we will have to call in, potentially other services from the state-based system, whether it's palliative care or other services. But if we're not looking at home care packages through that lens, and we're looking at more around home modification and socialisation and, cooking and things like that, which are all very important factors. But I'm just, one of the things that we really need to unpack, and we have so little data about what goes on, particularly in the home care packages. It is, the Royal Commission has really exposed that, I think, and even when they've tried to get the data, they've had to commission their own studies to actually try and get what do people spend their package on? What's the percentage that is spent on, clinical care or other care? So I think without that transparency and without people really understanding, if I'm on a level 4 home care package, I should be able to stay at home and get my palliative care needs met. Otherwise, why am I on a level 4 package if I don't have complex needs? And if I've got complex needs, at some point I'm probably going to require end-of-life care, and I should be able to get that. And if the package funding isn't enough at the moment to actually accommodate that, then we need to look at that as well. But we also need to, workforce issues is huge, I think, in the home care space.
Full of ironies, isn't it, Mike?
I thought it was very well handled. I mean, you came in, it was just tucked away very nicely. No, look, I think at the core, if you put yourself in a policymaker's position, and it's great to have the bipartisan support of our federal parliamentarians, because this is the big issue, and it's their issue. And if they say, look, we want to make a difference. There's various ways, but you just pick one issue, and the issue which I spoke about before is kind of where I go. That look, most Australians using consumer choice, so 3/4 of them would have a strong preference to die safely and securely with family and friends at home. You then follow through the economics. Now, it doesn't matter what bucket it sits in, Commonwealth or state, and sort of both kind of participate in ways. But at the core, that has to be worked out, because whatever economics you use, doing that, it's much cheaper than doing it through acute means or others. So, to have it in our hospitals, and you start to do the numbers, if the 50% remains, you're going to need dozens of hospitals, additional hospitals, just to deal with that demand. So in sort of basic public policy sense, before you get to the individual care that we want to provide to every single person that needs palliative care, it seems to me that there has to be a real focus towards delivering at home. And, I just look at this program, which is only done, I think, in New South Wales to a point. I mean, the panellists might confirm otherwise, but to actually deliver 73% is the number of people, of those 5,000 patients that we put everything into caring for, sort of died at home. That's a huge number that aren't in hospitals. And trying to deliver the best possible palliative care, I think that the natural challenge of the demands of acute hospital, make that difficult to take the time, to take that whole person-centred approach. It's just I'm not saying it can't be done, and it is done, but it's a real challenge. So I think on all of those levels, that's probably the best way the policymakers can think. What are the one or two levers that can make a real difference on the funding and the outcomes?
Alicia Mazzarotto, a geriatrician at Fremantle Hospital, asks, how does the panel feel about end-of-life care versus palliative care, and that split, and is the distinction helpful in an aged care setting? Craig?
Yeah, I think COVID's actually really shown this one up, and as we've looked at the visitation code for people coming in visiting, and even that distinction there that people have said, oh, you have to be having your last breath for someone to be allowed in, which I think is just shocking. Yes, there's been some hard decisions because of COVID getting into a facility, but the ability to have someone there and say, it's actually during that time when I want to be saying goodbye, I want to be actually having the discussions, that's when people want to connect, and then just saying, well, it's only at this end of life. So I think that it's a false dichotomy. We should be seeing this as a whole journey.
But if you sit back from this to pre-COVID, and we will eventually get to post-COVID.
Yeah.
When's that going to be?
Well, Queensland, Western Australia, South Australia, I mean, there's a lot of the country that is kind of, it's not post-COVID because it's still coming in, but we're not far away really from that in Australia, luckily. But my point is, coming back from that, some people in palliative care say there's no distinction between the two, is that if it's not going to be a surprise that you're going to die in the next 12 to 18 months,
correct,
you're in the palliative care mode.
Yep.
The difference would be what skills you need. Therefore, is it a useful distinction is what Alicia is asking.
Yeah, and I don't think it is. I think it's about where a phase in the journey. So I think that for the person themselves, they want to actually still have that connection, that support, those sorts of things. That I'll defer to my other panel members, but I think that there is still the want to connect for people, but they want to have adequate supports. And I think what Mike's talking about before is making sure that those supports, wherever they are delivered, are adequate and are right for the part of the journey you're on.
Mira?
Yeah, I think fundamentally we should be moving away from prognosis-driven care to needs-based care. And I think in residential care, when you have multi-morbidity and people with non-cancer diagnoses, actually predicting some sort of end-of-life period is very, very difficult. And if we spend all our energies trying to work out when that's going to be, we miss the boat in terms of actually having that person live well. I think having a sense that someone's prognosis is limited is a helpful starting point, but that shouldn't be the fundamental driver of the care that we're trying to plan and deliver.
Deb?
Yeah, and I think there's still confusion within the industry, and it's historical in many sense in that end of life for a long time was actually, the definition of end of life was actually the last days of life. And then when the Australian Quality and Safety Commission came out with their end of life definition, which was actually the last 12 months of life, but you could also be in the last week of life. So they sort of, pushed it out really. And so a lot of people still across aged care settings still use the term end of life to mean terminal care,
You're on your last breath.
Yeah, you're on your last breath. So we've,
which misses out on care.
That's right.
For a long period of time of their lives.
And palliative care really is the approach to care. And so, the way that I sort of look at it is end of life is to try and give you some sort of signposting as, do you have a life-limiting illness? What are the things that then you might need to plan for, and palliative care is the sort of the philosophy, the approach to care that can be delivered. And then specialist palliative care services are specially trained clinicians that can often assist and support you to do that. So that's how we sort of look at it in end of life directions. We sort of take the quality and the Commission's definition. And then we sort of unpack that in, we've got a model of care which has got 8 different components to it, which starts at advanced care planning and ends at bereavement care. But you go round the model and really what you're trying to unpack is, recognition that you're actually in the model, and then how do you assess, provide, work together, recognise deterioration, I think is a critical one. So it's not just actually recognise in the first place that somebody might be in that trajectory, but it's also then re-recognising
the path of the trajectory.
Yeah, that's right.
So, Mike, is this something that can go into a protocol, or is it something that you need new leadership in aged care to provide the culture?
Yeah, I mean, it more is the culture and mindset, and it's the long-term view. And to me, as a new kind of voice and eyes on that, I mean, I just see sort of end-of-life care as kind of missing a journey. I mean, that is part of the palliative care journey, but it's a long one. And I'll give you one example where someone who worked at Hammond Care, and he shared his story where he had the discussion with his father right at the end on what sort of funeral arrangements and what he wanted to have, and at that point he said, actually, we hadn't thought about that, but I'd like to sort of donate my body to science. And that would seem easy to arrange, but apparently it's 3 months worth of paperwork to enable that to happen, and so it was unable to be fulfilled, and that was just one small thing, but there was a bit of heartache that that's actually what his father had decided and wasn't able to do. Now, if it's you go on the journey and you have some of those discussions earlier, well, there's opportunities to consider all things sort of like that. So I think just taking that long-term lens and trying to be the best we can, and what's the best quality of life we can live in our last few months, and take into account personal choice and circumstances of family and the patient. I think that's going to lead to better outcomes all round.
Another question from Magnolia Cordonia, Associate Professor of Health Systems Research and Translation, University of Gold Coast. I assume that's Griffith University and the Gold Coast Hospital. How do you see the Australian health system moving to a culture where nurses, community pharmacists, GPs and social workers are empowered to prevent burdensome and unnecessary hospital transfers in the last year of life? Would this happen in the next decade? What do we need to do to achieve this, Craig?
We need a lot of coordination as well. We need, I suppose, this is another thing that we've seen during this period of COVID is it's no good sending a form and actually saying to someone, here's the form and sign this. That whole cycle of everyone being involved as part of the care team. We see it in prescribing around chemical restraint and those sorts of things, and the decisions that people even need to know about their medication. So I'm really pleased they talked about the pharmacists there as well, because it is all these different people as part of the care team that can help enable the choices of the person themselves. But at the core of it, it's what the person wants and what the older person wants, and they have to be part of that supported decision-making process as well.
Mira?
Well, I think I would say hospital transfer is a surrogate marker, not an end in itself. And I think sometimes it's become let's prevent hospital transfer at all costs. And
well, that's what state governments want to happen. They don't want
if we actually
transfers.
got the decision making, the assessment and the planning right, and then worked out what would be needed to deliver that care or that clinical event happened and how would we respond to that, and we had that all in place, then the response would happen in place with good outcomes for the resident, and hospital transfer would not be necessary. And I think we sometimes need to think about when hospital transfer might be necessary and what does that look like, and then it all becomes very, as you say, coordinated.
And people have the right to still have health. Yes.
The plea from the heart there is something that's systematic, that regardless of where you are in Australia, an aged care facility, the decision-making operates on the same principles and you're guaranteed some kind of similar outcome.
But I
That's
think
what sits behind that. And I'm
think
hearing a woolly answer, Mira.
You've got people with very heterogeneic conditions and complex needs, and I don't think you can say, let's just stop everyone from residential aged care needing to go to hospital in every single circumstance, and that will be our marker of quality. I don't think that's necessarily the right way to think about that.
But decision-making which makes it appropriate. I think that's, what's the system change there?
Well, and really that's what we're looking at as an outcome of the commission, isn't it? Clearly, we need system change, whether it's in the home care or residential care. So I think, yes, in a decade, yes. And if we haven't achieved that in a decade, then we've clearly failed the consumers that we're all, here to get the best outcomes for.
We have a question from somebody actually from Hammond Care, Melanie Lovell, who's a senior staff specialist in palliative care. We're not sort of...
I'm not sure whether she told me that was coming.
Yeah, no. But it's not to you. You'll be relieved to hear, Mike. And it doesn't sound like a career-ending question either. So, and it's really about palliative care when you have dementia. And is there such a thing as palliative care with dementia? How do you know? How do you manage it? It sounds like one of the hardest things of all in this area. And a lot of the clients, the people, the residents and so on, have some degree of cognitive decline.
Yeah, sure. Well, that's right. About 60% plus in residential aged care, we would say, would have dementia or some sort of cognitive decline. Yes, I mean, Hammond Care's just run a successful conference last week, the Dementia Conference, and a large component of that is looking at palliative care. I think one of the things that we have come to accept over the last decade is the fact that dementia actually is a life-limiting illness. And that palliative care needs to exist. And so we have...
So to have a diagnosis of dementia equals getting into a palliative care stream of some kind?
Not necessarily a diagnosis. I think what a diagnosis it should flag is that there is things that you should be putting in place and conversations that you should be having. And you should be having that regardless of what your life-limiting diagnosis is. So that's around your wishes, your values, where might you want to, be cared for, what might that look like? So dementia is one of those. The critical thing about dementia versus some of the other life-limiting illnesses is that you at some point will lose the ability to actually have those conversations and to express those wishes.
That's the point, isn't it? And can any curriculum possibly deal with that? Where, one of the wonderful things about palliative care is that you've got experts in symptom control and improving the quality of life. Yep. And so if you've got cancer or heart failure or other life-limiting illness, motor neuron disease, it kind of depends on a conversation between the professional and the person with the problem and their carers. And as you say, at some point you're going to lose that.
Yes, but you, because you have dementia, you don't lose the ability to have good quality of life. So I think that's critical. So I don't think that it's not exclusive. So palliative care.
But understanding as a professional what you need to provide for that person may be difficult.
No, I don't think it can be challenging, and I think there is skills required to understand that. And I think there is many people who have those skills, and we have again wonderful resources and training in Australia through Dementia Training Australia and the Dementia Centre, where people are being trained in dementia and palliative care. We have staff specialists who are dual trained in palliative care and geriatrics, so they get it. So I think we can train people to understand the palliative care needs of people with dementia and their family. And the family is absolutely critical in that conversation, because often it is the family who are there helping you and supporting, because they ultimately understand the changes in the person that is occurring.
One final question from Greg Crawford, who's an academic clinician, Northern Adelaide Local Health Network. The Palliative Care Australia KPMG report recommends specialist palliative care services into RACF. How is this going to be reliably supported and not fall between multiple governments and agencies? Mira?
So I think we're in a fortunate position that we've got multiple examples of novel models across the country, whether that be people within the organisation where we have palliative care nurses or nurse practitioners who have a lead role in a facility or in multiple facilities. We developed in Hammond Care a palliative care suite that was a standalone section within the facility that both looked after people with more complex needs. And then there's the in-reach models, partnerships with geriatric in-reach models. No, I think we're not poor for choice in terms of models that can be adapted to any scenario that would fit lots of different service structures. I think the problem is that often these are in demonstration projects or in evaluation projects, and we haven't then moved the next step to say how could we sustainably fund those. And we need to have a state to Commonwealth discussion to really solve that, because some of the specialist models are sitting within state models, and some facilities and organisations have taken initiatives to develop their own in-house models, but the funding that they use to do that is often through philanthropy and other means, and it's not core funding. And so I think we've got good ways of doing it. Yeah. We have to say, okay,
we do also
this is
have
the best way to
the initiative that it's been a bit slow off the ground, but whether it's COVID that's pushed people along or not, but it's the palliative in aged care matched Commonwealth state money. So there's $57 million on the table for the next for 6 years. Started in 2018-19. Most states and territories I hear have now signed up to that. So I think that's one of the things where if you can embed something that's matched money for a period of 4 or 5 years, get your model up and running, evaluate it, prove, and that's where some of the models that Mira's been talking around the country. Well, people do listen, because generally what you prove is that you can provide that outreach from your state-based service, that what happens is that you stop inappropriate hospital transfers into your public hospital system. And so the cost saving is never with the aged care, it's never with the feds, it's always with the states. So the incentive is to get the model right.
But I think just a last point on that, I think there is, if you take the principle that every Australian deserves the best possible death in the safest possible kind of circumstances, that sits in a federal jurisdiction, but you could do that in a way that provides less pressure on state government budgets. Doing that together, I think, is a big way to address it. Because there's benefits for both, but obviously that's been tried before, but we'll see how we go. But I think that should be the focus.
Feels like a Nobel Prize coming on here. Look, thank you all very much indeed. It's been a fantastic conversation, and I hope that you've got what you needed from it. And I refer you to the 8-point plan for Palliative Care Australia, which I'm sure has been distributed to you all. And it gives me great pleasure to hand over now to Ron Greenland, who is the CEO of Palliative Care Australia.
Well, thank you, Norman. On behalf of Palliative Care Australia, a really big thank you to everyone who has contributed to the success of today's event. In particular, thank you to Norman Swan. I think the entire nation is indebted to you for sharing your insights and your take on the challenges presented by COVID-19 over the past 8 months. This is, of course, the second time that Norman has kindly hosted a Parliamentary Friends of Palliative Care event this year, and we are genuinely grateful for that. And while we are meeting online, we hope that it won't be long before we can actually meet face-to-face again at Parliament House in Canberra. Speaking of Parliament, I would like to extend a big thank you to Katrina and Nola, the co-chairs of our Parliamentary Friendship Group. PCA is eternally grateful for your support, your energy and your dedication to palliative care over many years. I would also like to thank our special guests for their time, their insights and contribution to today's discussion. Thank you to Mike Baird, to Craig Gear and to Deb Parker. And my thanks too to the Chair of Palliative Care Australia, Professor Meera Agar, who has today launched our 8-point plan, which is aimed at ensuring palliative care is core business in aged care. PCA will continue to advocate for the 8 recommendations contained within this plan. These will ensure that all older Australians can access high-quality palliative care when and where they need it. To find out more about the plan and the work of PCA, please visit our website, palliativecare.org.au. Finally, let me say thank you to all our invited guests for your questions, which have helped shape today's event, and for joining with us today. Thank you and stay safe.